All right, everybody, we are going to talk about Parkinson's drugs. So just so everyone's on the same page, there are two presentations here. This one's mainly focused on the drugs. The second Parkinson's one is called treatment of Parkinson's, and that one's more on kind of first line, second line, all that. So let's get into it. General considerations. So just read through these. Big neurotransmitter that we're going to be talking about a lot today is dopamine. Dopamine. Sorry, that was there was a nurse I work with at the psych hospital named Daryl, and anytime he was him and I got pretty close or whatever, like joking around and stuff. He had a pretty good sense of humor, and he was he was a they had dopamine, and he was like, he also worked at inpatient at another hospital. So he's like, you know where they get the name for dopamine from? And I was like, no, actually, I never, like, I thought he was gonna give it. He's like, cause it's dope, nah, I mean. And I was like, oh, very funny, Daryl. Like, that's a good. But I laughed. I thought that was so. Anyway, so because of Daryl, I always think of dope, nah, I mean. But yeah, so dopamine's gonna be a big issue here. This is something that we're gonna be talking about. The other thing too is just this is a disease that you guys may know that Michael J. Fox has. So he's a public figure as far as signs and symptoms and kind of what he's going through and his struggles is a good reference point for people just because he's famous and a lot of people recognize him and know him in his movies. Back to the Future is an awesome movie. I don't know if you guys have seen it, but yeah. Anyways. All right, so now we have the dopaminergic pathways here, and this is what, again, is the main disruptor during Parkinson's. For testing purposes, for me, you don't need to worry about this pathway. I believe in ICM and pathophysiology, you will be seeing this, and it may be on their exams, so refer to those professors and ask them about that. But for me, this is just an FYI. And again, big take-home point, dopamine is going to be what is involved. General considerations here. So again, because of that dopaminergic pathway, it's good and bad. It's kind of a fine balance. So it's beneficial, but then there's also adverse effects, which we're going to see. So it is sometimes kind of a balancing act, for better or for worse, with these medications. This is one of those tables that is mainly FYI. If you are going to look at anything on this table, I would pay attention to this last column here, the effect of dopamine agonists. So this is a class of drugs we're going to talk about here in a little bit. But just know that unfortunately there are some adverse effects in here, some that we have to be concerned with. But as far as knowing which dopamine track they affect and which ones don't, again, for testing purposes for me, don't worry about it. But maybe pathophysiology, I believe, has some more specific questions and stuff that they'll be asking you about. But anyways, this is the only column rather on this table that may be beneficial specifically with the adverse effects. General considerations here. This is just basically FYI, and it's just showing you that there's these issues that people have with this disease, with Parkinson's disease. And other note too, just note extrapyramidal system, EPS, is an abbreviation that I'll use, and so I may refer to that. That's what I'm referring to. So EPS, I may say EPS symptoms, etc. We'll be talking about that again in the psych module. That'll come up again. And the other neurotransmitter that's going to come into play too, it's kind of a balancing act between dopamine and acetylcholine activity. So there's a balance there. So dopamine, if you'll remember from other lectures, is inhibitory, where acetylcholine is excitatory. And so too much acetylcholine can be bad, and too little acetylcholine can be bad, and same thing with dopamine. Too much dopamine can be bad, and too little dopamine can be bad. So it's this kind of a dance between them, and you try to have a proper balance. And so that's just what some of the therapies are going to be doing. So we're going to be modulating via pharmacological agents the dopamine and acetylcholine. So those would be these two main neurotransmitters that we're going to be concerned with and focused on. So because of what I just said, here we go. We have the ones over here that affect dopamine and anticholinergic, etc. So these are the classes. Make sure you know the classifications as per usual for my exams. First, we have here. So here are some popular drugs that are used. Just note too, these are from different categories. So if you go back here, there's from different categories. Also note too, here the carbidopa is a peripheral dopa decarboxylase inhibitor. So these are used in combination with the levodopa. Oops, sorry, wrong way. Levodopa, carbidopa, and entacapone. So you'll notice that is there. So the carbidopa is actually a peripheral decarboxylase inhibitor. You'll notice here, it's right here, listed there. And it really has little or no pharmacological activity when it's given alone at normal doses. So it's given in combination with things like levodopa because it's inhibiting this the peripheral decarboxylation of the levodopa. So it basically helps it prevent it from getting metabolized in the peripheral. And it does not cross the blood-brain barrier. So unlike levodopa does cross the blood-brain barrier, which is good and what we want. So anyway, so this is hopefully going to get more of that levodopa to cross the blood-brain barrier, and that you have more of it going to the brain. So then you hopefully will then have lower doses of levodopa needed. It also reduces peripheral formation of dopamine, reduces peripheral side effects, so specifically nausea, vomiting, and cardiac arrhythmias. So that's another advantage of giving the carbidopa in combination with things like the levodopa. So that's important to note too. So just in general, in summary, carbidopa allows for lower dosages of levodopa. You can do a more rapid titration of your dosage, so you can increase your dose more quickly. And then it helps decrease adverse effects. So kind of a three-pronged approach, 3 reasons why it's used in combination. Levadopa, also known as L-dopa, but that just refers to its chemical structure, and that's actually a precursor of dopamine. And this is able to cross the blood-brain barrier, the BBB, which is advantageous. So because the regular dopamine could not be used because it does not cross the blood-brain barrier, so you have to use the L-dopa form. And like I mentioned too, it is rapidly metabolized, and so giving it in combination with the carbidopa helps prevent that decarboxylation here. So anyways, and so that's why it's given with those. And like I mentioned, those 3 reasons. You give lower doses of levodopa, more rapid titration, and then decrease adverse effects of the levodopa. Mechanism of action, so the levodopa or L-dopa is able to go into the brain. It's quickly and kind of effortlessly converted to dopamine, kind of automatically. And then the dopamine goes and it acts on the CNS, dopamine receptors. Adverse effects, I talked about those, that too much dopamine can be a bad thing. So these are some things that if you have too much dopamine, anorexia, peptic ulcer, so GI adverse effects are a big issue there. You have to be thinking about. Hypotension is also an issue, especially so. Usually, it's just, the stereotype of Parkinson's. It's usually a disease of an elderly person, or older people usually get it. And so that is something that you have to be in increased concern with. So the elderly person may already be on other antihypertensive medications, or already have problems with hypertension. So they may be on other things that can cause hypotension. And then in addition to that, just with elderly in general, you want to be concerned with falls. So anything that can cause hypotension is something you need to be concerned with. So definitely put a star by that, remember that. And then GI adverse effects. Also note, I mentioned a couple of times, the carbidopa will help reduce these GI adverse effects and the potential for the hypotension. So another advantage of giving it in combination. You also have to worry about the arrhythmias, unfortunately, and then especially people are prone to it, so that can be a rare but serious one. Dyskinesia. So Parkinson's is a movement disorder, but then they can actually, if having too much dopamine can cause movement disorder. So read through these here, and I'd encourage you guys to get on YouTube, or maybe the other professors are showing you videos or whatever in your classes. But if you're interested in these are interesting and I think worth looking up YouTube videos for the dyskinesias affected with too much dopamine. Also related to too much dopamine is psychosis, which can again be problematic for any population, but especially elderly. If they're more frail too, that can be maybe more problematic with them. And then the hypersexuality too, a couple of different things that you have to be concerned with. So overall, more general or more common GI adverse effects, but really all of these are possible. And then too, with the dyskinesias too, I wanted to note too, a lot of times it is the longer they're on it, the higher doses they're on it. So someone like Michael J. Fox, he's been on these drugs for a longer time. He has some of these sort of classic dyskinesia. So you could also look, maybe look at videos of him if you wanted. All right, so now we're going here. We have the bromocriptine, which is right here as a dopamine receptor agonist. So this is nice classification, mechanism of action. It is a dopamine agonist that is able to cross the blood-brain barrier. This one is used as an adjunct treatment. So, and then it's also used for where people aren't responding properly to the L-dopa. Excuse me. And it has some other treatment uses too that we will be talking about more in the endocrine module. But yeah, so here's some other lists too that just know that they can be used for some other things as well. Pergolide, no longer available in the US, so don't worry about that. MIRAPEX, Pramipexole is the generic of that. This one is also a dopamine agonist. And this will... can be advantageous to use early on, and we'll get more into that. I'm kind of hesitating, but basically it's just used for the off symptoms and an adjunct to L-dopa. REQUIP, which is Ropinirole. This one, again, dopamine agonist, so note that. This one, Parkinson's, and also for RLS. Amantadine, which is SYMMETREL. This one you guys remember from the anti-infectious module, but this one actually is antiviral, but then also affects dopamine reuptake. So can be used for Parkinson's, helps with some of the movement disorders, and then can sometimes, it hasn't been for a couple years now, but a few years back it could be, or the CDC did allow it to be prescribed or recommended it to be prescribed for influenza A viral infections. So you just have to really check with the CDC and keep up to date with them. So some seasons, some strains of flu will be covered by amantadine and may be good to prescribe that, others ones not. And we have the adverse effects there to go ahead and note those. Selegiline and Rasagiline. We have the brand names there. Mechanism of action, dopamine agonists, and they also are monoamine oxidase B inhibitors. And then that's an enzyme that inactivates dopamine, so theoretically you have more dopamine going around. Usually used in combination, and then they make this the ELDERPRYL in a patch formation too, which can sometimes help compliance. Tolcapone, which is TASMAR, COMT inhibitor, which is an enzyme that ultimately leads to increased dopamine levels in the brain. So, and it's catechol-O-methyltransferase, which is COMT. So it's pretty interesting on how this one works. So the medication inhibits the COMT enzyme, which is important because so in the presence of a decarboxylase inhibitor, for example, the carbidopa we talked about, the COMT is going to be the major degradation pathway for levodopa. So it's another enzyme that we're blocking. So carbidopa blocks an enzyme, the decarboxylase inhibitor, and then the tolcapone blocks another enzyme, the COMT. And so then this inhibition of the COMT leads to more sustained plasma levels of the levodopa, and then it increases dopamine levels in the brain. So pretty interesting there. Usually used in adjuncts, and again, in addition to the L-dopa, carbidopa, because like I said, it's basically the way the body, shunts or pushes the dopamine. So first it would hit the decarboxylase inhibitors, the dopamine, to get eaten up or metabolized, and then it goes to the COMT. So usually it's the third drug that's used here. One big concern here, though, definitely put a star by it, hepatotoxicity. It is a US box warning. So because of that, there's pretty strict prescribing recommendations, I guess, from the FDA. But yeah, so definitely please note that and put a star by that for this medication. Entacapone, COMTAN, also affecting and inhibiting COMT. Huge advantage over this one is it does not have the hepatotoxicity concerned. And they actually make a tri combination. So if you remember my slide earlier, I had the brand name there. Let me go back real quick. So here we go. Here it's Stalevo is the 3-in-1 medication that they make with Entacapone. So definitely, if you want to go with a COMT inhibitor, please go with this one instead of the Tolcapone, just because you do not have to worry. It has lower incidence of the hepatotoxicity, so that's an advantage of this medication. Anticholinergic drugs, I mentioned too that the acetylcholine is something, and it is a neurotransmitter that we want to maybe hit. So first we have benztropine, and then trihexylphenadil. So these are anticholinergic medications. So they may help with the person with Parkinson's. They also can help with dopamine antagonists. So haloperidol is an antipsychotic medication that we'll be talking about that unfortunately can have Parkinson-like adverse effects or Parkinson-like movement disorders. And so you may see in the psych hospital or different hospitals, whatever, the benztropine, the cogentin being prescribed with haloperidol. And what they did at the psych hospital I worked at is they basically, if a person got an injection of haloperidol, we sent the haloperidol injections from the pharmacy with the little vials for the benztropine to be injected too. So they just basically injected both at the same time to help mitigate the movement disorders associated with haloperidol. But don't stress too much about haloperidol. We're going to be talking about that a lot in the psych module. Great summary table here. As usual, I like these. Pay attention to adverse effects and the contraindications. And that's it. So thank you guys for your time and attention. Stay tuned for part 2 on Parkinson's treatment of Parkinson's disease. And as always, email me if you have any questions. And thank you guys for your time and attention. I'll talk to you later.